Thanks, Rod. Impressive keeping to time, but also impressive the data, and it's very nice to be invited to follow on from that. I can't say that I'm going to match that, but it is, as Tony Blakely said, a very exciting time with big data on a sort of Scandinavian scale emerging, and really seeing it mature offers a lot of opportunities. And I'd just like to talk to you about NZX, which is one such opportunity, the multi-ethnic New Zealand study of acute coronary syndromes, which we have launched, and very grateful for the support of the Heart Foundation and the Healthier Lives Challenge. Vicky Cameron was actually going to give this talk today, but she's climbing mountains in Nepal, so I got roped into it anyway. Briefly, Jerry mentioned NZXTQ. Now, NZXTQ, for those of you that don't know, is an incredibly valuable tool that really came out of the work of the View Predict in primary care, and then Andrew Kerr, working with Rod and others, moved that into secondary care, and it now runs in every coronary care and cath lab in New Zealand, and we get excellent and very comprehensive data about pretty much every patient coming in with a heart attack in New Zealand. And that is basically the mission statement of NZXTQ. And we're talking about inequity of delivery of care to various populations, and it is extremely important looking at quality improvement, and a number of very valuable studies have come out of that. We now have an opportunity to link other research questions, more specific research questions, to NZXTQ, and this is NZX is one of the first of these, and it has been born out of our ability to now link a research component to NZXTQ. So here's a irritating picture, but similar to what Jerry put up. And so I won't really dwell on this, but we have a very comprehensive gathering of data, which is then, the NHI is encrypted, but we can link to outcome data for quality improvement. But similarly, we can now link research sets with specific questions to this data and have outputs. So we gained ethics approval back in April last year, and we are doing a very comprehensive survey of people coming in with first-time acute coronary syndrome, so first-time heart attacks, including a very comprehensive dietary questionnaire, biomarkers, stress, exercise questionnaire, and importantly genetics. So we're taking blood to subsequently do genomic sequencing, and this is going to be linked to all the NZXTQ data for the big database. So NZX, it's really about individualization. Where does me, where do you fit in New Zealand with acute coronary syndromes? We want to develop risk prediction models for coronary disease outcomes. Rod has shown how that is evolving very nicely. And from NZX, we'll be able to look at secondary risk equations as well as primary risk equations based on clinical data, but also biomarkers and genomic factors. We're recruiting a large cohort of New Zealanders with first-time acute coronary syndrome, so we aim to recruit 3,000 patients and a control population, which is going to be age, gender and ethnicity matched. And really it's about why. Why are people having heart attacks? How is this disease expressing in terms of at different ages and different ethnicities, and also response to treatments. And there's a huge variation in the milieu where acute coronary syndromes occur. So looking at gene, environment and interactions is going to be very important. So we're now up and running in 4 sites. So myself and Rob Doughty at Auckland Hospital, Andrew Kerr at Middlemore, Vicky Cameron, Richard Troughton in Christchurch, and Jerry in Waikato. So very grateful for the collaboration. We are now truly a multi-centre study, and it shows the power of the potential with NZXTQ. As I said, we're very grateful for the funding, and at the moment we've got 450 patients, but our recruitment rates are increasing. And so on that background, I just briefly wanted to talk about a study that Nikki Earle, research fellow who's been funded by the Heart Foundation, has done, looking at some NZXTQ data, looking at early onset acute coronary syndromes. And I think this will really show you the power of this cohort. Looking at data from 44 hospitals of people coming in with heart attacks, and about 9,000 with the first time heart attack. A quarter of those were aged less than 55. So if we look here in this column here, 3/4 of those were males, but a very large number and overrepresentative of Maori, Pacific and Indian subcontinent peoples in that young, early onset coronary disease. So coming in with a heart attack for the first time, age less than 55. And a very, very high risk factor burden. Half of them were current smokers. Obesity was very common, a BMI of greater than 30 and over half, elevated cholesterol, and diabetes in those presenting young was very poorly controlled diabetes. So just graphically representing that just very briefly, the incidence of smoking in these young early onset coronary disease patients was extremely high, but we can see some of the extremely high rates in Maori and Pacific. So clear targets for intervention. Similarly, diabetes, although the incidence of diabetes increases with age, it's still very high in this young age group and much worse control as well. BMI, we've seen other data, but extremely high BMI in certain ethnic groups in the young age group, and so the obesity epidemic is certainly here. So we have shown that this risk factor burden in these young coronary disease patients is extreme. What we don't know is what's the genetic risk, and could these people be identified at an earlier age for more targeted risk factor modification. If they knew that they were going to have a heart attack in their 40s and 50s, could you change their behaviour? One of the big questions. We have been very mindful with the research that we're doing, that with genomic research, the sensitivity around that, and from the outset we established a Maori governance group, and we're very grateful to all of those named here who have really helped us in the establishment of appropriate processes to establish this research so that it will very much along the lines of Te Mata era honour all of the obligations that we have to doing Maori research, genomic research, and we are certainly very grateful to them. So the potential that we have is to add genetic risk scoring to clinical and biomarker risks, and this is an evolving field. We've heard it how it's evolving in the cancer field, but genetic risk scoring for cardiovascular disease is certainly progressing very rapidly. It is now available. It's independent of existing risk scores, including family history. It does improve risk prediction when combined with other scores, and it does offer the opportunity for earlier identification of those at higher risk for more targeted efforts. And there is some evidence that improving lifestyle may attenuate adverse genetic risk. So identifying people at a younger age may be helpful. So that's MNZX. We believe it's going to be a valuable bioresource for genomic discovery, but also help us with risk prediction in the future, and is an example of where we're progressing with cardiovascular disease risk prediction. Thank you very much.